Good evening, everybody. A very warm welcome to the EUROGEN webinar programme. Thank you for being with us this evening. I'm here this evening to introduce the webinar and our speakers. I just also wanted to take a few minutes to explain that EUROGEN is a network of 39 healthcare providers with specialised expert teams in them who collaborate in order to try and improve care and treatments for patients with a rare disease or a complex condition. We're one of 24 ERNs that was set up by the European Commission in 2017, covering most medical fields. And just to mention a few things that the ERN does. Firstly, we provide highly specialised advice to any clinician in any EU country using a new system called the Clinical Patient Management System, which means that our experts can discuss cases virtually without the need for any patient to travel. And that's free for any doctor in Europe. The second thing that we do is we also collaborate really actively on clinical guidelines, and we do that with other ERNs and with all the major scientific societies. And it's fantastic that our patient representatives, who I'll introduce later, are also working on clinical guidelines. The third thing we do is training and education activities like the webinar programme. The Commission's also introducing something called the ERN Academy later this year, where all the education and training materials developed by all the ERNs will be findable in one place, in one platform. So we'll store all our webinars there, and in the future we hope to have some of the highly specialised surgeries videoed and again stored on that platform for training purposes. And then fourthly, we hope to be very active in the future on research, and such a large network of so many hospitals, it means that we can join forces and we have greater patient numbers when we need to look at various research aspects. We're also developing an ERN EUROGEN registry this year. So again, after the new members join the reference network this year, we should be over 60 members. So again, combining all the patient numbers into one registry will be incredibly valuable for research. And all healthcare providers in Europe, not just ones who are members of the network, will be able to enter their patients into the registry. So to summarise, I think we've got some really exciting developments coming up in the future. There's plenty to get involved in. So please have a look at our website and also our YouTube channel, and we're very happy for people to get in touch. So without further ado, I'd like to introduce our speakers here this evening. I'm so grateful to them because it's fantastic that we have patient representatives who are really willing to raise awareness about some of the issues that they're facing. So it's incredibly valuable to the whole of the network. So firstly, we have Rob Corns, who is a male specialist nurse who's dealing with information on rare male cancers. And he's working with one of the UK's leading charities on male cancers, and it's called Orchid. So he'll be the first speaker. And then we also have John Osborne and Kenneth Manzie. And the three of them, I'm delighted to say, are in our official European Patient Advisory Group. So all the topics that I mentioned that we work on together, we also work on with patient representatives. So that's a new development, that we've had them there right since the very beginning of developing the reference network. And luckily, more and more patient reps are joining us, like the great group that we have here this evening. So I will now hand over to Rob without further ado. And again, thank you so much for sharing your experience and expertise with us.
Okay, so hopefully you can see the presentation screen. The title of our presentation is Penile Cancer, Yes, There Is Such a Thing. And the main reason for using that title is the simple fact that there are many people out there who don't actually realise penile cancer exists. And I'm not just talking about the general populations of Europe, but this can extend to healthcare professionals working outside of the field of cancer. And the main reason for this lack of awareness, which can impact on the diagnosis and treatment of penile cancer, is simply because of its rarity. And if we take a look at some of the diagnosis rates for Europe and the UK combined, we can see that it is a rare cancer. There's only around 5,300 men diagnosed each year in Europe. And when we compare that to testicular cancer, which itself is considered a rare cancer, we can see that it's actually about 5 times less common. And if we compare it to prostate cancer, the most common male-specific cancer, which will be diagnosed in the EU, with vastly underestimated numbers, we can see that it's really just a drop in the ocean. And that's why people don't tend to talk much about penile cancer. But the problem is that although it is exceptionally rare, out of all the male-specific cancers, it comes with the biggest consequences on physical and psychological adjustment, because all curative treatment is inevitably going to involve some form of surgery to the penis itself. And I'm going to be covering a couple of problem areas in a second, but I just wanted to talk a little bit about the surgical side or treatment side of things. In the UK, we're in a fairly good place in the fact that anybody who is diagnosed at a local hospital with penile cancer, where there may not be experience of treating it, will be referred to one of 9 specialist centres or regional centres, supra networks we call them, in the UK, where there will be dedicated urological surgeons and teams who will do their best to perform penile preserving surgery. And on the whole, there will also be specialist nurses and other supportive services who can help men as they go through treatment. And on the whole, we know that this works and the standard of care and treatment is excellent. So it's not so much the treatment that we have issues with, it's more 2 particular areas. The first is the actual route to diagnosis, which can cause us problems. So we know that some research has suggested that it can take men up to 3 months to actually go and seek advice from a healthcare professional, having found something unusual down there on their genitalia or penis, which isn't normal. Now, penile cancer is exceptionally rare, and a lot of healthcare professionals or GPs may never have seen it or treated it, so they don't recognise it for what it is. And as early symptoms of penile cancer can mimic some non-cancerous conditions, such as candida or thrush, STIs, or some skin diseases, what tends to happen more often than not is that the initial treatment will be usually topical creams or lotions. And when these haven't worked as well as they should have done, men will usually be prescribed a second course of topical treatment or referred to a dermatologist or referred to a sexual health clinic. And another 3 months can go by before anybody actually realises this is penile cancer. And the majority of men I've spoken to in my career, I would suggest that it's more like 9 months before they actually reach a diagnosis. And research has also suggested in the past that up to 1/5 of men may have a delayed diagnosis simply because of inappropriate referral. And 9 months is a long time to have a cancer that hasn't been treated, especially as the treatment will be surgery, and the result will be a much more invasive type of surgery and a much bigger consequence to men after treatment. So one of the messages we're trying to get across as a charity is that if there is something down there that doesn't improve after an initial course of treatment, rather than be referred to dermatologists or sexual health clinics, men should be referred to urologists who will obviously have some idea of penile cancer and will be able to start the ball rolling. The other big problem area we have is what happens after treatment. How do men adjust to life after penile cancer treatment? And here we have several hugely impactful problems. The first is, as surgery is the main course of treatment, the penis will not be the same as it was. That can be difficult to get used to. It can have an impact on sexuality and self-worth. A lot of penile cancer surgery will also result in spraying of the urinary stream, which can be difficult to control and obviously embarrassing. Men who have a full amputation of the penis will have to sit down to pass urine. And we can't forget that men who have had diagnostic procedures looking at lymph node involvement or lymph node surgery have a real risk of ending up with lymphedema, which can be a life-changing and long-term problem. And not only have we got the physical effects, we also have a huge psychological burden. As I said, the penis will be different. It may not be as functioning as it was. There will usually be an impact around sexuality, body image, and masculinity. And if we combine that with the fact that these men are often isolated with nobody around them who can appreciate what they've been through, this can cause a real psychological impact. Now, an intervention for this would be counselling, which we know does work, obviously, for cancer patients. The problem here is that we're dealing with men who are less likely to open up and talk about their feelings and their fears and worries. And one of the things we're actually just trying to do at Orchid at the moment is we have a telephone counselling service for anybody who's been affected by testicular or penile cancer. And what we're hoping is that the added anonymity of being at the end of a phone rather than face-to-face will encourage men to talk, to open up, and hopefully improve the well-being. Now, on a similar vein, we know that a very important and useful thing for anybody who's recovering from any cancer is peer support. And this can radically alter how people adjust and how well they adjust. And for instance, in the UK, we have 95 prostate cancer support groups. As a chairman of one myself, I know that these can be invaluable, a place where men can share experience with somebody who actually knows what they've been through and can help support them in the longer term. The problem is that because penile cancer is so rare, it is extremely difficult to create that same sort of support for men outside of regional centres. There are a couple of very good penile cancer support groups at the moment in the UK, and we have tried to create meetings and workshops where possible. But the problem is that the vast majority of men will not be able to talk to somebody else who knows what they've gone through and who can give that support. So this is another logistical problem which can impact on recovery. However, having said that, and for anybody who wants to find out more, there is an excellent closed Facebook online support group, probably the biggest support group for penile cancer in the world. It's a closed group. It's called Penile Cancer Awareness and Support. And providing men know that there will be people who are in good places and bad places, it's an excellent source of support and discussion. And has proved invaluable. Although the majority of men are from the UK, there are certainly a number of men from as far afield as America, Canada, and Australia. And I think in the absence of physically meeting support groups, it's an excellent opportunity for men to share their experience. So that was a very quick overview of the situation with some of the issues we're facing. And I'm going to stop there and hand over to John, who will talk about his experience. And I'm sure some of the issues I've spoken about will be obvious. Thank you.
Hi. Hi. Can everybody hear me?
Yeah, we can hear you, John. Yeah, the slides into presentation.
Yeah, just 1 second. Okay, can you see the presentation?
Yeah, we can just see it in normal mode at the moment. So. Okay, yeah, great. That's it. Excellent.
Okay, well, good evening, everybody. And first of all, I'd like to say a big thank you for giving your time and your interest in this subject. As you will see by the end of the presentation, our aim is to raise awareness and understanding of this disease and the implications it has for men like myself who've had the condition. Many of the things that Rob has mentioned in his presentation, I will be repeating. Actually, there were several of those aspects that were very much part of my journey. What I must say is that what follows are my personal reflections and of my cancer journey. But I've spoken to other men, and I know that men who've had penile cancer, and they have shared similar experiences and share my views. I also know that there are some people who don't share those views, and they experience their cancer very differently. And I'll talk a bit more about that later. Perhaps the central message that we want to convey this afternoon is that ignorance is killing men. Like others, I had no idea until I was diagnosed that there was such a thing as penile cancer, which is a really stupid thing, really. I mean, a penis is just another organ of the body. But so why shouldn't it get cancer? But I think that's one of the things that we're up against when we're talking about penile cancer, because it just doesn't appear. It isn't alive in people's imagination, really. The other thing about penile cancer, and I think it affects many of the men who have it, and certainly it did me, was the stigma that is attached to this illness. We all know that men are not very good at going to the doctors to seek help and support in the first instance, but you know, that may be embarrassment. But I think when it's penile cancer, or even anything to do with your genitals, men avoid going to speak to a doctor, and that can cause some of the issues that Rob mentioned in relation to delay in receiving treatment. The other thing, though, is that when you talk about having penile cancer, and I have never had any particular problem about discussing my own cancer, but quite often the response can be very unsettling. I can remember people asking me, well, what have you done to deserve that? Where have you put it? Very upfront. Some people find it even very difficult to have the conversation. They don't want to talk about it. Oh, what a horrible thing, don't talk to me. So you're battling against that as well. What we need is to raise awareness and understanding so that we can get the very best person-centered support for men possible. My journey started in 2015, in October. I noticed a small red mark on the base of the glands of my penis, and I went to see my GP after a couple of weeks. Initially, I thought it would just go away. It didn't. As Rob said, I was given a cream to apply. A month later, I went back because that wasn't doing any good. I was given another cream, a steroid cream. again, after an initial slight change, back again to the GP, who on this occasion referred me to a dermatologist. I asked to see a male dermatologist, and needless to say, when I arrived, it was a female dermatologist who I saw, and because she was female, I had to be chaperoned, and they couldn't find a man, so I had another woman come to assist. So again, a pattern starts to emerge, and you soon discover that it's quite difficult. It's very literally it is exposing, but actually it's also you can feel very vulnerable. The dermatologist wasn't sure what was happening, but just in case, she took a biopsy, and 2 weeks later she contacted me and she told me quite emphatically that I didn't have cancer, which again was a bit of a surprise to me. Whether it was avoidance or just stupidity, you choose, but I hadn't really considered cancer as such. However, she was concerned that there were some cells that were a bit of a concern, so she referred me to a colleague urologist. Because I hadn't, because I've been told I hadn't got cancer, I went to see the urologist alone on a Friday evening, late one Friday evening, and I was fine. I was everything was perfectly normal. After the initial pleasantries, he examined me, and immediately his demeanor changed, and he said that we needed to have a very serious conversation. And he told me that he thought, yes, I did have cancer. And within minutes, he was talking about surgery and even reconstruction. And it was just such a shock. It was a real surprise. One that I wasn't ready for, one that I didn't really want to have. And as he said, he wasn't the person who would be performing it, but he needed to refer me on. I just suggested that we left it there, and he made the necessary referrals. But the roller coaster had started running, really, and one of the things that became very clear very soon was that time is of the essence. I went to see my my surgeon, which is in one of the super networks which Rob referred to, and I was treated in Leicester. As Rob said, the treatment is surgery, and my first operation, I had 3 operations in 14 weeks. The first one was what my surgeon euphemistically refers to as a somewhat radical circumcision. They circumcised me and cut away the cells that they felt that were the cancerous ones. That's done under local anaesthetic, and is quite. I had a very attentive nurse trying to talk to me about holidays and best favourite places to eat, which of course didn't work. I just wanted to get on with the operation. The second, I was discharged the same day, and it's a very difficult few days after the first operation. I didn't really understand or appreciate what was happening. I didn't know what to expect. I'd had to be included into a surgery list very at the last minute, so had not had some of the preparation from some of the nursing staff that I otherwise would have had. So it's really quite impactful, that first change. The second operation was a sentinel node biopsy, which is not always available in all parts of the UK, but this is quite a complex and complicated procedure, and in fact in Leicester it even involves 2 hospitals. You start at one and prepared for the surgery, then taken by taxi to a second one, where you spend 2 hours with the radiologists in the Department of Nuclear Medicine, who the radiographers just take multiple images of you and are sort of pushing the slides to get the right images. You then go back for an ultrasound to identify any lymph nodes that are responding, and then the fourth part of the day is the surgery to remove any lymph nodes. It is a tough day, very tough indeed. But actually, it's one that was quite a relief to get through. As Rob mentioned, the policy is to preserve as much of the penis as possible, and so the first cut is not always the deepest. And I needed a third operation to remove some cells that were looking suspicious after the biopsy. They actually forgot to take those cells away at the point of the sentinel node biopsy, and it probably was a good idea that they did, because like many people, I had a response to the sentinel node procedure, which was I had a lot of problems with lymphedema, which exist to today. The other thing though that was noticeable was you tend to find these people say, "You don't mind, do you, if?" This is usually said by somebody who has already done something and is then seeking your approval for it after the event. Or it may be somebody walking into the room, "You don't mind, do you, if?" We're joined by a student who's working with this at the moment. When I had my sentinel node procedure, that student was an extremely attractive 20-year-old who spent most of the morning on the X-ray bed with me, holding the different slides. It was a very strange experience, but you get to know people quite well very soon. You also become a bit of a there is a danger of becoming seen as a diagnosis, not a person, and particularly with a rare cancer, there is a lot of interest. You're the penis in bed number 4 rather than John, who's in bed number 4. The thing that really sort of knocked me sideways with the first operation, as I mentioned, was I didn't anticipate some of the psychological effects that would happen. Again, strange it may seem, but it really was, I'd got somebody else's penis. It didn't look like mine, it didn't behave like mine, it didn't feel like mine. And it took a lot of getting used to. There were issues about questioning my whole sense of who I was as a man. There were issues about whether I'd be able to have sex again. There were issues about whether what I was feeling was normal. And I desperately needed to speak to somebody. And so I started looking for post-operative support. I went and talked to, I contacted one of the specialist urology nurses, who seemed surprised because her response was, "Men don't want to talk." And I would say, well, this one does. I really needed to talk to somebody and to check out whether or not the experiences I was having were the same as other people, and whether it was what the possible outcome for all of that might be. Don't get me wrong, I'm eternally grateful for the support I've had, and it's now nearly 5 years, and I will be hopefully discharged after my 5-year post-operative treatment, and my surgical team have been brilliant. But I think I really do not want my surgeon to be my therapist. That's not their job. That's not what they're there to do. But I think, like the majority of men I have spoken to, I was offered no counselling or post-operative support at all. And you basically are sort of left to get on with it. There are the follow-ups, the medical follow-ups that you have initially every 3 months and then every 6 months. And that's all absolutely fine. But it's really this sort of suddenly finding yourself in this new position, and all the questions that you have. there's a desperate need for good information and advice. There isn't a lot around, and one of the things that I became an ambassador for Orchid after this experience, because I wanted to try and get the word out there about this condition. The way that came about was, as Rob mentioned, there is an advice line, and the nurse that did speak to me and said that men don't want to talk did actually suggest I looked at the Orchid website. And again, that was really good advice, because I was able to find the date for one of the phone call helpline meetings, and I phoned and spoke to Rob. And it was a very important, life-changing conversation, really. Because Rob was able both to offer me good practical advice and reassurance, but also he listened and reassured me about what was happening to me and how that might be, how my experiences were similar to many others. He also talked about the Facebook and Messenger group that he mentioned earlier. And I joined that group and have been a member of it ever since. And it is a remarkable thing. It's an incredible group of men. The Facebook group is for families and families as well as men themselves. The Messenger group is solely for men alone. And they're a great source of information, knowledge, advice. But the Messenger group particularly is also somewhere where men can go with and talk about their deepest fears. It is not unusual for us to lose a member of that group each month who have died as a result of their cancer. And I think that's one of the messages that we want to get across. If you need treatment quickly. One of the things that happened with me was the pathologist who did the first biopsy also did my second biopsy. And he couldn't believe it was the same patient, because the cancer was aggressive and it was moving very quickly. Despite those first few months of not being able to get treatment, I was seen just in time. Had I not been seen at that point, I could have lost half, if not the whole, of my penis. That is devastating for anybody. I think we as men who have had penile cancer are the male genitally mutilated, and we need support and advice and understanding. So some of the shared themes, to sum up, awareness or lack of it is a real issue with penile cancer, and there is a great need for more information and advice. Orchid have been trying to get some money together to put together a special website like the one they have in relation to testicular cancer. It's very, very difficult to raise money to support penile cancer initiatives, and that is also causing major problems. Stigma, I've mentioned already. But one of the things as well is that people think that penile cancer is an old man's disease. It isn't. In the Facebook group we have men who are diagnosed in their 20s, 30s, and 40s, and so it isn't. Although the majority of men are much older, it still affects people at younger ages. Everybody's sort of cancer journey is unique, and we want people to be seen with in a rounded, holistic way that provides both the excellent clinical support, but also the psychological support and the various supports that Rob mentioned also. One of the things that psychosexual sort of counselling, I have never I don't know anybody who's been offered that. The post-support networks, I think we've mentioned, and I'd say no more about that. But certainly key messages. Misdiagnosis is common. Of all the men I've spoken to who have had penile cancer, they have had a significant delay in their treatment or been misdiagnosed at some point. We've already mentioned the issues about timing. Stigma, again, I'll keep saying it, it's one of the ways that impacts on the way people view and treat people who have this condition. Lack of knowledge in primary care is undoubtedly an issue for me, and psychological support is rarely offered. One of the things I said at the beginning was that these were my personal reflections, and some men deal with their cancer very differently, and that's absolutely true, and as it should be. Quite often I've met men who've had, a couple of times rather, I've met men who've had a total penectomy, who have approached it from the point of view, well, I'm over 70, what do I need a penis for? And if that's how they cope with it, that's absolutely fine. The issue though for me there is that it sometimes closes down other men who need and want to talk about their condition. They don't have the same bravado about it. It also reminds me of a guy that Rob and I met a few years ago, whose daughter had put him in touch with us because he wanted to talk to somebody else who'd had the condition. Again, the rarity issue here comes in. We met a great guy who, again, was one of the I'm over 70, what do I need a penis for type, was his opening remark. Within a few minutes, he completely changed and told us all about the ways in which his life had been completely changed as a result of his cancer, how he saw himself, how he viewed himself. He was a lifelong rugby supporter, but because the toilets at the rugby club he attended, there was only one stall and just urinals. He had completely cut contacts with the rugby club, which had been such a major part of his life. These are the things that people don't get a chance to talk about. The other thing that people don't often talk about is sex. It's almost like we're not there. What do you expect? You're not. Why should you? Why should you have a sex life after this? You should be lucky. You know, we've done what we can. If you can manage without it, we've saved your life. But that is not an easy thing to do. Part of our work as EUROGEN reps, I think Michelle touched on most of these at the beginning, but we do attend these strategic board meetings with clinicians. We are working on developing the clinical guidelines on penile cancer and with the European Association of Urology. And I think it's really good to have a patient perspective in those meetings. It's a remarkably difficult task putting the guidelines together. Contributing to educational webinar programs like this, I'll leave you to judge how educational and informative this has been. But promoting the use of EUROGEN Registrar, the patient portal that Michelle mentioned, and the ability for penile cancer patients to benefit from the knowledge shared across the network by all the various clinicians working in it, where they can discuss and share patient notes and experiences and advice. It also works very well for clinicians, as there is this is clinicians in Europe. Unfortunately, the UK is no longer part of this post-Brexit, but where clinicians can work in networks on virtual advice and diagnosis and management of penile cancer. And there's also training initiatives there where clinicians can visit each other's hospitals and each other's places and learn more about this rare condition. Thank you. I think that's my part of the presentation complete.
Thank you, John, and thank you, Rob, as well, for those very interesting presentations. Thank you for being so honest about everything. So we haven't got any questions at the moment, but if anybody wants to ask any questions now, please do. We've got a few minutes. Yeah, also, just while we're waiting, again, let's say thank you to John and Rob, and just say to everyone, if you found this webinar interesting, please let us know your thoughts. We're sending out a survey tomorrow. I think I will be, no, actually may not be a survey with this one, I apologise. So if you have any comments or feedback and you don't want to say anything now, please send your comments, thoughts and questions to me afterwards. That's not a problem. Please also check out our website for future webinar dates and titles. You can also check out all our past webinars on our YouTube channel as well. So please subscribe to that. And you'll be able to watch this video back in case anybody joined late. I know people were joining, some people were joining throughout. So anything you've missed will be available tomorrow on our YouTube channel and also on our GoToWebinar platform as well. I'll send the links out directly to everybody who registered for that as well. Yeah, so if anybody has any questions, please put them in now. We'll give it a couple more seconds. If not, please feel free to send things afterwards. We just know what people thought about today. Okay, I think if we don't have any questions, then I'll say again, thank you very much. Really appreciate it to John and Rob for that, and to Kenny for joining as well, who's his own background. But yeah, it's a very interesting presentation, very thought-provoking as well. So thank you guys, and thank you also to everyone who's attended as well. So please don't hesitate to get in contact with me afterwards if there's anything you want to ask. But otherwise, say thank you for now, and take care all, have a good evening, and we'll see you all soon, hopefully. Okay. Goodbye.